Welcome to our colorectal surgery clinic at St. Alphonsus. We know this is a difficult situation and diagnosis that you are dealing with, and our goal today is to help you understand this problem and the treatments we have to offer you to treat your rectal cancer. Colorectal cancer is the third most common cancer diagnosed in the United States, with over 140,000 cases diagnosed this year alone. Fortunately, we have standardized protocols for the treatment of rectal cancer. Once you have a better understanding of the problem and its treatment, we will help you develop a plan of care specifically for you and your situation. We have assembled a highly skilled and caring team that will guide you through each step of your care and recovery. Now let's meet the team. Hi, my name is Sheev Dattani. I specialize in minimally invasive colorectal surgery at St. Alphonsus. I have an expertise in the surgical treatment of rectal cancer. My team and I will be helping you throughout your journey, and I will be performing your operation. Most of the operations I perform are minimally invasive, meaning through small incisions, which speeds up your post-operative recovery, shortens your stay in hospital, and gets you back to doing the things that you enjoy. I will be meeting with you and your family throughout this process. Next, meet Dr. Johnny Green. Dr. Green is a colorectal surgeon with over 30 years experience. Dr. Green assists me in surgery and is involved in your care in the clinic and in the hospital. Next, we have two physician assistants, Rob Bazzini and Katie Nichols. They are part of our team and will see you in the clinic and in the hospital, as well as help during your surgery. Next, let's talk about what rectal cancer is. The rectum is the last several inches of the large intestine. It starts at the end of the final segment of your colon and ends when it reaches the short, narrow passage leading to the anus. The rectum sits in a tight space, barely separated from other organs and structures. This tight space can make surgery to remove the rectal cancer complex. Rectal cancer usually begins as a polyp growth in the rectum. The cell in the polyp may become abnormal and begin to grow uncontrollably, unlike normal healthy cells. This is how a polyp transforms into cancer. These cancer cells then invade the muscular wall of the rectum and can spread into surrounding tissues, lymph nodes, invade the bloodstream, and may even travel to other organs. There are several risk factors for developing rectal cancer. Most of the time it's just bad luck. 80% of the time, rectal cancer is sporadic. 20% of the time, there is a genetic component. There are some risk factors, however, such as old age, African American descent, a personal or family history of colorectal cancer or polyps, inflammatory bowel disease, inherited syndromes, a diet that is low in fiber, diabetes, obesity, smoking, alcohol consumption, radiation therapy from previous cancers, and not enough exercise. Now let's talk about the most common symptoms of rectal cancer. Most colon and rectal cancers are found without any symptoms. Usually they're found on routine colonoscopy for screening. This leads to colon and rectal cancer being found at an earlier stage. When patients do develop symptoms, they may develop a change in bowel habits, dark or bright red stool, narrow stool, a feeling that the bowel doesn't completely empty, abdominal pain, unexplained weight loss, weakness, or fatigue. Understanding how rectal cancer spreads helps us determine the stage of the rectal cancer so our team can determine the best treatment plan for you. Staging also helps us understand the prognosis related to the cancer. Staging a rectal cancer answers the following questions. How far has the cancer grown into the wall of the colon or rectum? Has the cancer spread to nearby lymph nodes? Has the cancer spread to distant lymph nodes or distant organs? Fortunately, you are not alone. Roughly, there is 40,000 cases of rectal cancer diagnosed every year in the United States. This has led to very standardized treatment protocols and very standard staging workups. The staging workup for your cancer includes blood work. The first thing we check is your blood count, a metabolic panel to look at your organ function, tumor markers such as a CEA, and next, a CT of your chest, abdomen, and pelvis. This will help us determine if the cancer has spread to other organs or to the lymph nodes. MRI is one of the most important things to stage rectal cancer, as it tells us how deep the tumor is, whether there's lymph nodes involved, and any other high-risk features associated with the rectal cancer. So how is rectal cancer treated? Rectal cancer is treated by surgery alone, or a combination of surgery, chemotherapy, and radiation, depending on the stage of the tumor. Sometimes the rectal cancer is found very early, and surgery is indicated first. Other times, the rectal cancer is slightly more advanced, and chemotherapy and radiation is done to help shrink down the tumor to help ensure a better margin and easier tumor removal and less of a chance of recurrence. And this again is based on the stage of the tumor. Other times, if the tumor has spread to other organs, treatment may include chemotherapy and radiation, and perhaps more chemotherapy prior to surgery if indicated. All of our patients with rectal cancer have the benefit of their case being presented at our multidisciplinary tumor board with our panel of experts. This tumor board is made up of medical oncologists, radiation oncologists, pathologists, geneticists, and other surgeons. We will discuss all of the details of your clinical history, laboratory tests, images, and pathology of biopsies with our team. We use the National Comprehensive Cancer Network guidelines that are nationwide as the foundation of our recommendations. These are the same guidelines used at all other major cancer centers, including the Mayo Clinic and Cleveland Clinic. After the tumor board reviews your case and makes a multidisciplinary recommendation, this will be presented to you by our team at your next appointment. Stage 1 rectal cancers are found generally quite early. This stage includes cancers that were part of a polyp. If the polyp is removed completely during colonoscopy with no cancer in the edges, sometimes no other treatment is needed. If the polyp margin is very close, perhaps a transanal approach may be offered. Sometimes the tumor is deeper into the tissues and an abdominal surgery is offered. For small early stage cancers, sometimes a transanal approach is offered, which is done using a few small instruments and a camera, and the tumor is removed via the rectum. A lot of times this is a day surgery where the patient goes home the same day. They have minimal to no pain. Unfortunately, this is not an option for all tumors and all rectal cancers. For patients that are not eligible for this type of approach, a low anterior resection, proctectomy with coloanal anastomosis, or abdominal perineal resection may be done. Depending on exactly where the cancer is located within the rectum, we will select the best choice for you. Additional treatment typically isn't needed for stage 1 tumors unless we find the cancer is more advanced on the final pathology than what was thought before surgery. If it's more advanced, sometimes patients are offered additional chemo or chemotherapy and radiation, although this is on a case-by-case basis. Stage 2 and 3 rectal cancer treatment. Many stage 2 rectal cancers have grown into the wall of the rectum and may extend into nearby tissues. They have not spread to the lymph nodes. Most people with stage 2 rectal cancer are treated with chemotherapy and radiation followed by surgery, although the order of these treatments may differ from patient to patient. For example, here's a common approach to treating these cancers. Many people get chemotherapy and radiation first, called chemoradiation, as their first treatment. This is followed by generally robotic surgery, which includes a low anterior resection or sometimes an abdominal perineal resection, depending on where the cancer is in the rectum. Additional chemo may be given after surgery, usually for roughly 3 to 6 months, and this is usually discussed with your oncologist. Treatment for stage 4 rectal cancer is somewhat more complex. Treatment is personalized for each patient depending on their situation, and we follow very closely the NCCN guidelines. Sometimes treatment may include surgery, depending on the situation, Sometimes they include chemotherapy and radiation, followed by surgery, and then maybe additional chemotherapy after. Sometimes the cancer is too widespread, and this is treated by chemotherapy and sometimes local treatment to any other organs that are involved. The decision making for this is complex, and a lot of times this is done with your radiation oncologist, your medical oncologist, and involvement of our multidisciplinary tumor board. Now that we've covered some of the basics of rectal cancer diagnosis, staging, and treatment options, let's discuss what's next. Step 1 is to meet with me today so we can review your symptoms and tests you've had. I'll be performing a physical examination, which includes a rectal examination to determine the distance of the tumor to the sphincter complex. We will also be checking your heart and lungs, as well as determining how fit you are and your nutritional status. At this visit, we generally set up referrals for you and our medical and radiation oncologist if indicated. In addition, we will order remaining tests you will need in order to accurately and complete your staging of the rectal cancer. Next, in step 2 of your care plan, I will be performing a flexible sigmoidoscopy in the endoscopy center at our hospital or in the clinic in order to precisely determine the location of the tumor. This may influence the treatment and surgery you will be offered. You will have completed your medical and radiation oncology consults, and we will be presenting your case at our tumor board. Next, in step 3, you will follow up in our office with me and our team to go over all results, endoscopy findings, and recommendation from the oncologist and the tumor board. Then together we will make a decision about the next steps of treatment and whether surgery is indicated first or chemotherapy and radiation followed by surgery. Wow, we've covered a lot of information. Listen, this is a really important subject, but don't feel like you have to take any notes or memorize everything we have discussed. Our team will make sure this video is available to you with other information that will help you feel more prepared and able to manage through this process. Most of all, we want you to know that our team will be with you every step of the way. Thank you so much for watching this video. We will be right in.